international project. We have visiting partners from Stockholm, from Finland and Sweden today, so the conference will be fluent in English. My name is Breivik. I work at the Norwegian Center for eHealth Research, and I am the project manager. And this is my colleague.
My name is Mathias Halvorsen. I'm coming from University Hospital of Norway. And my colleague from the National Center for Child and Adolescent Psychiatry who will we will use the microphone. We will share this conference during this day. Hopefully it will be a nice day and interesting presentations. I will give the mic back to Edin, who will share the first session.
Thank you. I would like to welcome Einar Bugge, the Deputy Managing Director of the University Hospital of North Norway.
Thank you very much. First of all, I wish you all a very warm welcome to this eCAP conference. What can technology do to deliver better psychiatric services to children and adolescents when we know that the need generally exceeds service capacity? That is what this conference will explore today. This conference is organized within the frames of the European eCAP project with partners from Scotland, Finland, Sweden and Norway. Through eCAP and together with the Norwegian Center for eHealth Research, the University Hospital North Norway has implemented video consultations with the Child and Adolescent Psychiatry department. With Skype for Business, the young people can sit safely and hopefully comfortable in their own home, in known surroundings, and talk to their caretaker. I think that is a very major step forward. At which is the short form for our hospital, we have a quite proud history of housing the Norwegian National Telemedicine Center for many years, a part of which was some 2 years ago transformed into the Norwegian Center for eHealth Research. Much important and valuable research has come out of these structures, as well as important contributions to innovative solutions for modern healthcare services. However, this is my personal opinion, but I think it is no secret to many of us that implementation of telemedicine and modern e-health solutions in daily practice in our area has not been quite as rapid and profound as one could wish. The good news is that I am quite optimistic that this will change over the coming years. In the North Norway Health Region, we now hope to launch a new innovation program on how to secure the necessary support for a much wider implementation of modern e-health and telemedicine solutions in daily work in our hospitals and outpatient clinics. In this respect, the eCAP program is an example to follow, and we are very proud of and grateful to the dedicated work by many of you here have done to develop and implement this video consultation-based solution. We are heading towards a near future with an aging population, a rapidly rising population living with multiple chronic disorders, and also a substantial lack of nurses and other healthcare workers. Overall, and certainly in our region, sparsely populated and with large distances, I am absolutely convinced that the development and implementation of new health technologies, and especially e-health solutions, will be of great importance and a prerequisite if we shall be able to meet this future. The most important aspect to have in mind when innovative healthcare solutions are developed and implemented is the opinion and preferences of the users, which meets the patients. This has been taken very well into consideration in the eCAP project, and I now have the great honor to introduce the next speaker, a person who knows more than any of us about the mental health services given to young people, Mr. Mathias Halvorsen from the Youth Council at Bugge.
Thanks a lot. Thanks for a nice introduction. Anyway, as you said, I'm Mathias Halvorsen. I'm 20 years old. I'm born and raised here in Tromsø. I have cerebral palsy and scoliosis, and I'm a member of the Youth Council. On top of that, I'm also a law student here at the University in Tromsø. Now, onwards to today's topic, which I've chosen to phrase as the future of healthcare from a youth perspective. Now, I looked at this topic and I thought, wow, this is huge. I thought, oh my God, where do I start? And I was like, oh my God, there's going to be so many people here, and they're going to be from, they're going to have a lot more professional knowledge than I do, and I'm going to have to talk in English. How am I going to do this? But then I looked at this again, and I thought, well, hang on a minute. I have a chronic disability, which in fact many of, or all of the Youth Council members, all of the current Youth Council members have chronic challenges, whether medically or psychiatry related. And I thought, I have a chronic disability. None of my stuff goes away entirely, which means I, or we, the Youth Council members, will be dependent on good health care for many, many years. And I thought, well, based on this, two particularly interesting questions can be raised. The first question is, what do we consider good health care from a youth perspective? Now, in the Youth Council, we discuss this all the time. It's what we do. It's what we're based upon. Our vision is to find out what would be good health care for the youth, and what we've figured out so far, and what we're working to get you professionals to understand is that good health care for the youth is a system where our knowledge of ourselves and our challenges are considered a resource and not something that's sidestepped and overruled by professional experience based on old, outdated and inconsiderate practices or fancy doctor's lingo. At the same time, while we're incorporating us as a resource in our own medical or psychological treatment, do at the same time be aware that we are a vulnerable group of patients. We have our own perceptions of rights and wrongs, do's and don'ts on all aspects of life. Also the case when it comes to our medical or psychological treatment. Let me give you an example. If I'm not sure about moving away from the safe kind of boundaries of the children's section on the day I'm turning 18, then don't push me to do so. Make the transition from the children's section into the adult sections and clinics. Make it smooth and do it in cooperation with the young patient. Same. Another example is that if I'm 22 years old and want my parents to be by my side during the challenging treatment or conversation with doctors, then please let me do so. I know it's efficient for the hospital to not have to put in an extra bed for my parents, but it's all about me feeling seen and heard in my treatments. And we want to be seen and heard, no matter how small our concerns or preferences are. The second question then is how can we utilize eHealth to achieve this, to be sure that the youth are seen and heard in their own treatment. Now, technology today develops at an amazing rate, and healthcare and health services need to follow along with that progress. As we youths are online constantly now, it should be easy for us to have access to our doctor, our clinicians, and our health information online too. I mean, as easily as you can be dragged down by likes and comments on social media, as easily as that can influence your mental health. You should really be able to have a psychologist bring you back up again just as easily via Skype. And it should not be necessary for anyone, least of all for adolescent patients who are very vulnerable, for a good group of patients, to travel several hours by bus or boat due to the distances to get qualified psychological or medical opinions and help. And Unn has thankfully now realized this and are actively using Skype sessions between therapists and patients for psychological consultations. It's just like a few clicks and then you're in. And that is good for youth health. I think that deserves an applause, actually. Now, in addition to getting the right help quickly and in the smoothest way possible, another thing that's important for us is quick and easy access to information. And let me give you an example for myself. If one of the metal rods in my back, which effectively holds my back up straight, should somehow loosen or break, I mean, that's very unlikely, but well, if it was to happen, it would need an urgent a pretty urgent fix, and it should not be dependent on me remembering to grab the X-rays from my drawer as I run to the hospital, as I hastily go to the hospital, probably in much pain, I would imagine. In the Northern Health Organization, or the Helse Nord, which it is part of, you have full access to your medical records from online. But since my operation was done in Oslo, which is not part of that kind of digitalization progress and project, none of the documents that I would need for the doctors to know what to do would be available to me without me remembering, or without the doctors having to apply for permission to view those documents. And that would mean a few extra hours, I would imagine, of pain for me, quite frankly. And this could be avoided if we get all health organizations realizing the importance of, if we get all health organizations to realize the importance of e-health and the potential that lies in e-health services, and how efficient it could be. Realize the potential and do your best to promote the possibilities that are there. If you do that, we as youth who are constantly online and have a lot of knowledge on what's going on in the online world would be really happy. On behalf of the Youth Council, it's really been a pleasure speaking to you guys. To summarize, I just want you to remember this: we are not children, nor are we adults. Our treatments and the way you approach us needs to be adjusted accordingly. Now, we are youth. We are youths after all. We are not children, nor are we adults. Thanks for listening.
Project has been funded by the EU Commission through the Northern Periphery and Arctic Program. And this has been a 3-year project. Thank you.
Forgot about the mic again. So I'll repeat myself. This eCAP project was funded by the EU Commission through the Northern Periphery and Arctic Program. And it has been a 3-year project. And for the next 2 hours, we will learn more about the eCAP project from our 4 partners from Scotland, Finland, Sweden and Norway. And although the partner regions in these countries face similar challenges and problems, their healthcare systems are differently organized, and the partners have therefore chosen different approaches to meeting or solving these challenges. So first, I'd like to welcome our Scottish partner from the Centre for Rural Health in Inverness, Phil Wilson and Mr. Thompson.
Let's try this. That was a great introduction from Mathias, actually, because he talked about some of the problems about avoiding bad healthcare, actually. It's not just about providing good healthcare, and our project makes... our project is to start with, about avoiding some of the bad things about healthcare. Now, my name is Phil Wilson. I'm a general practitioner. I'm not a mental health specialist. And this project, in part, was designed to help non-experts in mental health, but people who are dealing with children and young people with mental health problems. This is a team effort. Lucy Thompson's going to take over from me in a minute. She has done a lot of work on this project. But also Jerry King, who's still back in Scotland, and Pam Sheriff are also important members of the team, and they regret not being able to be here today. So this is the problem that we tried to resolve. Jerry coined the term the Bermuda Triangle of mental health for children and young people. And the Bermuda Triangle consists of 3 corners. One of them, Child and Adolescent Mental Health Services, Child Psychiatry, Child Psychology. Another corner is Paediatric Services, and another corner is the Social Services. Now, I know that in each of the countries that are taking part in this project, that there are problems in deciding initially which service is the best service for a child or young person with problems. So if I'm as a general practitioner, if I see a young person with very, very severe behaviour problems that's been excluded from school, for example, those problems could be caused by maltreatment, they could be caused by the fact that the child can't hear properly, they could be caused by ADHD, they could be caused by autism. There are lots of different possible causes, and I, as a general practitioner, may lack the skills to decide what the best service for those problems is. Obviously, if the child's being maltreated, then the first place to go would be social services. If the problem is ADHD, then the problem might be best seen by Child and Adolescent Mental Health Services or paediatrics, and that depends on where you are. So our idea was that an online diagnostic system which the parents and child or young person and teacher could give information to, and which would be assessed by a mental health specialist, whether that online system could help to direct the child or young person to the right service. Because we as GPs, for example, have to deal with some really difficult problems where we make a referral on to a specialist service and then they say, no, we don't do this. And so you wait for several weeks, and it's bad for the family, it's bad for the GP, it's bad for the relationship, it's particularly bad because the young person has to wait longer to get the service that they need. So, this looks like it comes from 100 years ago. This is, and actually it's a very ancient piece of software called the DAWBA, the Development and Wellbeing assessment. It was actually invented after computers were invented, believe it or not. It's, as I say, it's an online diagnostic system. And it's a package of interviews and questionnaires, and it's designed to point to a diagnosis. It can be used between the ages of 2 years and 18 years. Actually, it can be used for young adults as well. And it covers pretty much all the mental health problems that children and young people have. In every case, it would be completed by a parent, or in almost every case. Some of the much older children can just complete the thing on their own. But parents will do it in almost all cases. If there is a teacher involved, so for children over 5 and young people, then we would ask for some teacher to put information. And if the young person is over the age of 10, then the young person themselves will input information as well. In our pilot work, the completion of the form was supported by research nurses, but now it's just done entirely online. Most importantly, the questionnaire information that is put into the software is rated by a child psychiatrist, so it has to have an expert assessment before the results are sent back to the person that's made the referral to the system. This is what it looks like, and you'll see there are essentially this is a psychiatric interview, which if any of you have done child psychiatry, child and adolescent psychiatry as a profession, you will realise that when you're a very junior psychiatrist, it's very boring. You have to go through lots and lots and lots and lots and lots of questions, and the answer to almost all of them is no. But this actually takes away that hard work of asking about everything, and you'll see that there are all the different kinds of symptoms that a child or young person might have as part of their mental health difficulty. And the parent or child or teacher completes the questionnaire in this way, answering either no or yes, a little or a lot. And then they just carry on through the questionnaire. And on average, it takes the parent, if the child or young person hasn't got many problems, it will take them a bit less than an hour. If they've got lots and lots of problems, it will take them about 2 hours to complete. And then, when the answer is yes to any of those questions, then the parent is asked for, or the child or young person or teacher is asked for a little bit more information. So there's free text that's entered as well. So here that the box has been ticked saying that there's a specific fear and other fears, and the person completing the questionnaire fills in information about that extra fear. And then there is an additional, when there is a symptom, there is an additional invitation to fill in more information about the specific symptoms, and you'll see there is quite a lot of free text here as well as the yes/no information. When all the information is completed, this is the output, and you can see here that there are 4 columns. There's the parent that's completed the questionnaire, there's the teacher information, there's the information that's completed by the young person. And you'll see that not all the sections have been completed by all the people. Okay? Because if deliberate self-harm is not part of the problem, this is actually a young person aged 6. Self-harm was not one of the symptoms reported, so it's not that section has not been completed by the respondents. And you'll see there are lots of pluses, which means that there's quite a lot of that symptom, and you'll see that there are different ratings given by the different respondents. And so there is then the final column is the prediction, which is based on an algorithm based on very large numbers of psychiatric interviews that were done when this system was developed. And here you'll see there's quite a lot of symptoms reported, quite a lot of likely diagnoses reported. This is an example of Sorry, that last one wasn't the 6-year-old, that was a 14-year-old, sorry. This is based on an actual questionnaire that was completed as part of our study. This is a 6-year-old boy, and this is the final summary report that was made available. And you can see here that there are, the mother has reported a number of autism symptoms and some PTSD symptoms. This is the rest of that section here. A lot of hyperactivity symptoms, some oppositional defiance symptoms there, and the likely clinical diagnoses, which you'll see on the right-hand column, hyperactivity and oppositional symptoms are the things that are most likely to be actual diagnoses. So here's the bit that's really valuable. This is the information that goes back along with that summary report, along with with the pluses and the minuses. This is the bit that's actually potentially useful to the clinician. So I, as a general practitioner, am very pleased to get this comment back. So what it says is, DAWBA scores highly for symptoms suggestive of attention deficit hyperactivity disorder and oppositional defiant disorder. Although the parent does report possible autistic traits, these could also be explained by ADHD and are not sufficient by themselves to seem to indicate an autism spectrum diagnosis. So that's based not only on the yes/no questions, but also on the free text that's given by the parent. In Highlands, which is where we are, ADHD is primarily assessed by community paediatrics. So you see there's a problem. In other parts of Scotland, for example, ADHD is seen by child psychiatrists. So it's difficult for non-specialist clinicians to know who does what in the mental health field. So in Highlands, ADHD is primarily assessed by community paediatrics. And then finally, a little teaching point from the psychiatrist that wrote this report: oppositional defiant disorder is generally a diagnosis of very little clinical benefit. So we've had a little bit of teaching in there as well. So that's what the DAWBA looks like to a clinician like me who's referred parents to get that assessment. So at this point, Lucy will take over and tell us what actually happened.
Okay, I'll just hold it as well, that's fine. Thank you. Okay, so I'm not a clinician, so I'm here to talk about the research side of it. So Phil actually led on this pilot when I was away on maternity leave, but we conducted a pilot in 2015-2016 where we allowed general practitioners to refer to us any young person they felt that there might be a mental health concern, and they would automatically be allowed to use the DAWBA if they wanted to, just to do a little bit of feasibility work. Is this something that non-specialist practitioners will use, want to use? We had 26 referrals into that pilot study, of which 24 actually completed a DAWBA, and they did do it over the phone that time, with the research nurse actually walking them through it. And then we did some follow-up survey work and interview work with both the participants themselves and the general practitioners who'd taken part. So it was a good pilot, it went well. As you can see, they're the most common sorts of diagnostic categories that came up were oppositional defiant disorder, whether useful or not, generalised anxiety, ADHD, depression, those sorts of things. We learned some good lessons from the pilot around how to develop this to go into the bigger trial. Understanding the place of the DAWBA. For example, if you refer a young person to have a DAWBA assessment online, this doesn't mean that you have referred them to an onward service and they're off your desk, as it were. We had to explain to general practitioners that this should be seen as a triage tool, and it's to help them make their clinical decision about onward referral rather than being a point of referral in itself. And as Phil's already alluded to, the use of a very brief report format was very much appreciated by the GPs. The automatic report that comes from the DAWBA is 18 pages long, and it was agreed that they should also have a 2-page summary because that was more useful to them. And the 18-page version is more useful to the specialist practitioner. And some GPs in the interviews did report that they had actually changed some of their case management based on the outcome of the DAWBA. So it seemed promising and worth going on to do a randomised controlled trial to see if it actually could make a difference for young people. So our research question was, can using the DAWBA as a triage tool result in improved mental health in children and young people, reduce waiting time to services, and improved appropriateness of referrals? Our design is a very simple RCT, DAWBA versus usual care. We also made it very clear to people referring in that referring a young person to receive a DAWBA assessment shouldn't preclude them from going ahead and referring them to a service anyway. They should carry on and do what they were going to do anyway, and we'll see if kind of tagging the DAWBA onto the side makes any difference. So it can be any child aged 2 to 17 for whom a concern about mental health is raised, and of course their parents and teachers. Now the referrals in this case, so the pilot was just with GPs, and what we decided to do for the trial was to have GPs, paediatricians, health visitors, which are the public health nurses for the under 5s, school nurses, primary mental health workers, who I will say a lot more about in a minute, educational psychologists, and eventually teachers, which I will also say a little bit more about. And our primary outcome measure is the Strengths and Difficulties Questionnaire, or the Mental Health of the Young Person 6-month post-recruitment, as reported by the parent primarily. So, we've been recruiting since April 2017. It has been very challenging. I think most of what I'm going to talk about today is about those challenges and what we've done to overcome them. But despite having very positive response to the trial, we just weren't getting the numbers of referrals that we'd been led to believe we could expect. And on average, on a kind of month-by-month basis, we were getting around about 30% of what we had targeted for our referral rates. I think we learned pretty early on that some of the issues that lay within the system locally that made some of this sharing of information, making sure children were actually getting to the right service in a timely manner, were actually hampering our research as well. This is just an example of the sorts of rates. So along the bottom here you see some of the professional groups that we were seeking referrals from. GPs are on the far left, then teachers, primary mental health workers, paediatric doctors, health visitors and school nurses. Educational psychologists aren't even on the chart because we kind of almost gave up on those right away because they were never going to be referring into the study. So this is as of April this year, and you can see that far and away GPs were the ones that were keen on this, were seeing it as something useful and were referring into the study. And actually, in reality, it was a specific, it still is a specific group of GPs. Those who already start to refer are the ones that keep on referring. And we have had some teachers, which I'm going to say a little bit more about in a minute. Primary mental health workers are a group of professionals. They are part of child and adolescent mental health services. Psychology, psychiatry specialist services sit at tier 4. Primary mental health workers are at tier 2, so they are mostly out in the community, in schools, and their job is to assess and provide support, ideally so that children don't have to get to the stage of requiring tier 4 services, but also to decide if that is, what the right location is. So, what did we actually do to try and engage with practitioners in the first place? When we first started, we went out to meet with the various groups. GPs, there's too many of them, but there's lots of very well-established ways of communicating with GPs. So we use newsletters and our usual kind of primary care fora to get out to GPs. They were easy to communicate with in some ways. We went to meetings of health visitors, school nurses, primary mental health workers, explained the study. Again, very positive responses. Everyone's like, sure, we've got loads. We're going to refer hundreds of kids to you. You're not going to be able to cope. Now, this, as you already have learned, this did not happen quickly. GPs started to refer, but pretty much the other groups didn't. And we had feedback quite early on that we were going to have teachers referring into the study. Now the way it works in the Highlands specifically is we use the Highland practice model where we have a named professional for each young person. And usually when they're of school age, it will be the primary school head teacher for the children in the under 12 age range. And then when they get to high school, it's their guidance teacher in high school is the named person who is responsible for coordinating the child's plan and knowing what's going on for that child. So we felt it was appropriate that guidance teachers be allowed to refer into the study, so long as there was a clinical colleague nominated as well. When this full DAWBA report comes out, it would be going to a clinically qualified professional to deal with how to feed that report back. And the teacher gets the 2-page summary only. And ideally, they're working in collaboration in working with that family. I think that happens a lot, but I think it doesn't happen as much as the system thinks it should happen. So I've got a case study here. See how easy it is to scroll down this. Sorry, I'm trying to see my notes here. It's not going to work. This is where I brought my iPad on, just in case. Okay, so forgive me, I'm going to read this straight off the slide. So what we had with the teachers was we went out to visit different schools, and generally they would all say, oh, we have so many young people, you're not going to be able to cope with all the referrals. And by the time we got to the third school who said this, the first two had not given us any referrals. We said, yeah, sure, we've heard this, I'm sorry. You have to try and beat these other schools because, I'm fed up of hearing this. So they referred 14 people to us the next day, which was great. And actually, I think it resulted in 12 referrals where the parent was actually happy to be referred in. So all 12 referrals were made on the same day by phone. Only 3 of these referrals actually consented to take part in the trial. Of the 9 referrals not continuing, 1 young person didn't wish to participate. They were 17 years old, so 1 young person and parent declined to participate after receiving all the information and discussing it with the research nurse. 2 were not contactable at all. 4 parents were happy for the trial document pack to be sent out, but then they were not contactable after that. And nothing was returned from them. 1 completed the trial informed consent, which was returned to site, but then they were not contactable after that. Multiple phone calls and letters are sent in these sorts of circumstances, but it didn't come to anything, so those did not proceed to randomisation. So although we had a lot of referrals, the actual conversion from referrals to randomisation is extremely challenging. These families are in a situation of perhaps not crisis, sometimes crisis, but certainly some level of chaos when their young person is experiencing such problems. So it is proving quite difficult. We have recently met with the Head of Education Services in Highland to send a letter out to all schools to try and get another little recruitment drive going. Our experience so far of the trial has been whenever we try another strategy, we get another big lump of referrals like this. So we've done a lot of work, and I'll say a bit more about this in a minute, about understanding the role of primary mental health workers, who we thought would be a good source of referral from schools. And then one of our other strategies was to utilise the waiting list. We have a new neurodevelopment assessment service in Highland, which I think started up about 2 years ago now, was it, Phil? It was around about the time we had our meeting, yeah. So it's finding its feet and figuring out, but it has a big waiting list. So we thought, well, perhaps we can approach people who are waiting on that list to see if they would like to have a DAWBA whilst they're waiting, obviously with the chance of, given that they would be randomised, there's a chance they wouldn't have it. I'm just making sure, I've got notes here again, I'm just making sure that there's nothing I'm missing from that. Yeah, so letters went out, and again, we've had quite a positive response. And I'll give more about the actual figures that we've got to so far. So what we've tried to do is be creative about how to manage this. We thought this would be straightforward based on our experience with GPs. It hasn't necessarily been so, but we've tried to use different kind of creative ways of actually getting people to refer in. Now, our qualitative evaluation with participants are, we follow participants 6 months after they've been randomised, and we get SDQ data from them, but we're also interviewing families where we can. And that process is ongoing, but again, they have proved very difficult to arrange. We need to wait for a paper consent form to be returned, and that's often just too much. I mean, who uses the post these days? So it's kind of hard for people to fit into their routines, I think. So far we have 2 carers, 1 mother, 1 grandmother have been interviewed. And unfortunately, neither of those were actually randomised to receive a DAWBA, so we haven't had feedback yet from someone who received a DAWBA. But I can just read out a case study of the interview from a parent. This mother described her son as extremely anxious and fearful. She couldn't remember a time when he wasn't anxious. He didn't want to go to school, and it seemed like he'd spent the whole day being nervous and anxious. She described it escalating to a point that she thought was quite irrational. He often worried about getting into trouble and being sent to prison. He was referred by his GP. He was 12 years old when he was referred. Previously, he'd seen a child psychologist. He said the psychologist thought there was enough evidence to show that he was on the autistic spectrum. His mum was not keen for him to be labelled as autistic. When he was referred to eCAP DAWBA, she hoped it would be dealt with in a low-key, calm way. Although she understood the DAWBA as a triage tool, she seemed confused about randomisation. He wasn't randomised to the DAWBA, but she thought he didn't fit the criteria, so he had care as usual. He was referred to his primary mental health worker, and she saw him at home 3 times, and that went very well from the mother's point of view, and her son seemed to really like her and responded well to her visits. Since then, things have been better. He still has issues with food, but is happier at school and doesn't seem so anxious. She feels he is maturing and has ways to support himself now. She was very positive about the support he received through a primary mental health worker after school. Now, when we went out and spoke to the primary mental health workers, our colleague Jerry ended up interviewing them individually, because what actually happened when we saw them as a group face to face, they were very positive. This sounds great, we're going to refer loads of people, and then we did not hear from them. We have had 1 referral from a primary mental health worker in over a year. So the case study I've just described is quite an interesting illustration as to part of the reason why. From the primary mental health workers' point of view, they're doing what we are trying to do with the DAWBA already. So to some extent they feel, on one hand, maybe there's no point in us using the DAWBA, but also perhaps a little bit threatened by us using the DAWBA. This is a summary that Jerry's provided of the feedback that she got. So again, initially enthusiastic, but upon discussion with colleagues, they seemed to think maybe they didn't really want to take part in this after all. They were struggling to see it as a useful tool. I've listened to a couple of the interviews. I've heard one of them say, we don't really know if it's going to make a difference. And our response is, yeah, neither do we. That's why we're doing the research. Can you help us figure it out? But you know, that general feeling of, we're going to make up our mind already. We don't think it's going to make a difference, so we're just not going to take part. And then there was quite a lot of resistance to the medical model of care. The primary mental health workers in Highland, there's about 10 of them, and they come from diverse professional backgrounds. And most of them don't really confer to this medical model of mental health, whereas compared to a general practitioner, for example, they're going to be very much primed to see mental health in this sort of way. And the wanting to avoid labelling is all part and parcel of that. And as I've already said, we're already doing this. We are the DAWBA. Why do we need to take part in this? There was some misunderstanding about the role and how it fitted with them, which we think we've explained and helped to change. And we generally felt there was a bit of a group think going on amongst these professionals as a group, that when you spoke to them individually, they seemed to have a good understanding and be very receptive, but when they get together as a group, there seemed to be a general mentality that they didn't want to engage with the study. Yeah, not sure if we're supposed to be referring, don't know what we need to do now. They had pieces of paper that told them, so it's very interesting. So they have communicated a willingness now to look and see who they could refer, and now that they have a better understanding of the study, and they're feeling very positive about teachers being involved. This hasn't resulted in any referrals from primary mental health workers yet. It's been fascinating. So, this is actually old information already, because based on going to the Neurodevelopmental Assessment Service waiting list, we had another sudden flurry of referrals, and yesterday we got referral number 100. Now, we initially planned to run the recruitment for a year, starting in April 2017. So we've already managed to extend beyond that, and we're going to continue recruiting beyond the life of the actual eCAP funded study as well. We are converting roughly to about 50%, so of those referred, about 50% of those are actually agreeing to take part and go through to randomisation. So we're going to keep recruiting to the end of this year, so we'll be able to break the randomisation code next June, once we've got follow-up data on all of those people, assuming we get follow-up data for all of those people. And of course the main outcome, as I've already said, is the STQ follow-up, but I think, and I've been saying this for some time now, the main thing that we're going to learn about is the process, the qualitative side of things. We've had some really interesting discussions in the steering committee with people who are quite senior in the services about what this tool can do, but also trying to implement it, what it actually reveals about the services and the potential blockages within the services. So although we're doing this from our own point of view, from a university as a research study, I think the learning for the services is going to be quite significant. And that's us.
Well, thank you, Phil and Lucy. Are there any comments or questions for our Scottish friends?
Well done, guys.
Thanks. Okay, Frank.
Yeah, thank you, Phil and Lucy, for a very interesting presentation about I learned a lot, and I think we learn when we are. What do you think about what is the best practice? Do you think how to implement this kind of tool?
Thanks, Frank. What's been very interesting is how this research has already been disruptive, even though we haven't got the results yet. My guess is that the DAWBA will make the service more efficient. Is that better? Yes. My guess is that using the DAWBA at the first point of concern will make getting children to the right services more efficient. But that's only a guess at the moment. Certainly as a GP, I've referred 3 or 4 people into the trial, and I've actually found it useful in every case. In one case, I made a decision not to refer a young person because the DAWBA had ruled out the diagnosis that I was concerned about, and in others it did provide some useful information that I could send along with a referral to a service, which was found useful by the service. So my guess is it's probably good practice to do it, but we'll have to wait until next June to know whether it actually makes a difference to mental health in me.
I think getting evidence for it is difficult because randomisation is a barrier. The process of filling out baseline measures, going through informed consent, and then finding out you may or may not get this intervention, which we are obviously saying we don't know if it's effective or not, is a barrier to people. I feel if we were able to just say to people, here's this resource, go ahead and use it if you like, we would start to see differences, but we obviously want to generate evidence for that before we would invest in doing so. So it's one of those real tensions you have in trying to do applied research, where actually how can you get the evidence easily? Well, you can never get it easily.
I could maybe just give an example of, in a different field, how this tool could be useful. When we've been explaining to GPs the way in which the DAWBA might help them, we've started to use an analogy of a blood test. So if a patient comes along to see us and they're yellow, then they could be yellow for a number of reasons. They could have hepatitis, or they could have a blockage like gallstones, and the different types of problem leading to the patient going yellow will mean I would send to a different service. So I do a blood test, and if it's one kind of result, I will send them to a surgeon, and if it's another kind of blood test result, I'll send them to a physician. And the DAWBA really would do the same kind of thing. And in a way, no one now, I don't think anybody's ever done a randomised controlled trial of doing a blood test for patients who are yellow, but actually it's pretty obvious that it actually helps to make things more efficient.
Any other comments or questions? Thank you. So, the next presenter will be our partner from the Eastern University of Finland, from Kuopio. Okay, you're all coming, so maybe you should introduce yourselves.
Good morning, everybody, and greetings from Finland, Norway, Kuopio. We are the Finnish team. My name is Hannele, and there is Kirsi, Jussi, and Minna. And we are going to present as a team what we have done there in Kuopio and in the Norway area in eCAP project. And actually, when this project started, we had also two other members who are now emerita professors. So Professor Kerttu Tossovainen was at the beginning of the project leader of this project, and Professor Kirsti Kumpulainen also. Quite many of you have met her. They are now emerita professors. So what we have done. The main purpose in our project was to launch a video consultation service to Child Psychiatry in Pohjois-Savo in Kuopio area. So we will tell a little bit about the background and what activities we have done in the project, and also some feedback from the users and some results of our survey. And also thoughts about how we managed to implement the service and what are the future views of using the service. As a background, in general in Finland, there is a different kind of activities going on all the time, of course. One of those at the national level is that the main target of our government has been, I think, almost 20 years, we say in Finland, but very, very hot topic the last 3-4 years is to integrate and restructure the social and healthcare services in Finland. So you can think about when we are developing this project in Norway area, it also affects how it goes. The other issue in Finland is that at national level we are developing a kind of virtual hospital system and different kind of care paths. So this is in line in that general development work what is happening in Finland. And when we come to our region, the Norway region, it's a kind of we have a lot of mental health problems in this area in Finland if we compare to other parts of Finland. And at the same time there is lack of professionals to take care of these problems. So as was mentioned already, our aim was to develop a kind of video conferencing system between healthcare professionals who are working in the primary healthcare in the region and with specialists in the university hospital, as Minna and Jussi are, for instance. And of course, it meant also develop multi-professional collaboration between different professionals and also specialists and so on. And also we tried to increase the general knowledge related to mental health issues, so that we organized also different kind of training for our professionals in the region. And of course the main goal was to get better care more equally and timely for our patients and clients. at the beginning of the project, we carried out a survey to get a kind of understanding that what is the situation from the professional's perspective. So here are some results of this survey, and you can see that it seems that there is room for development. For instance, if we look at the statistics about previous experience of using video conferencing, no experience from VC unit 75%, and so on. So we felt that there is a lot of need for this kind of activities, what we were doing. And also when we asked willingness to take part in VC with specialists in psychiatry, there was a kind of variation. So, for instance, depends on how easy it is to use and would be necessary, and so on. So, okay, then I believe Jussi will continue talking about these activities during the eCAP project. So please.
Okay, good morning for everyone. I'm Jussi Karppi, as you can read, and we had this kind of a over-optimistic hope to be also doing the DAWBA project, but it diminished to hope, and then we found ourselves in the graveyard of all projects with that. But this video conference thing, consultations between mental specialists and the basic primary healthcare workers is something that we can still say something about. This was the thing, the chart that we were thinking that we will be doing. We will be having a simple video conferencing machinery that can be used in any kind of computer. As you know, nowadays everything can be easily online, basically. And so that any kind of primary healthcare worker or teacher, and the guardians can also collaborate with that, even child can reach the help. Basically, actually, we were trying to get the school nurses to call us so that they can more easily decide what they should be doing, what they could be doing, what they would do. Like kind of doing the what they were trying to do with the DAWBA, we were trying to do it with a personal contact with the specialists. We were that kind of blood sample test. We had also these SDQs that could be could help us to decide what kind of symptoms the child would have and in what kind of situation he or she lives. And we decided to try to make online fillable forms on them. And also we have this Finnish form LAPS or small LAPS, big pull-ups form that does this even a more simple way, 14 checking questions in each of those. Okay, yes. And if the school nurse, for example, has the worry about the child, so he or she could simply just book the time appointment for video consultation and see me or my colleague there and have a good conversation on what he or she could decide what to do. Okay, the next. This is what it looked like at the first stage. There was this simple online calendar, online booking system, and it looked quite all right. There were 3 joint rooms, online rooms that were had these 3 roles for well child clinics, 1 for school health care and 1 for family counseling clinics. Okay, as we heard before, we learn from problems, and we have plenty of them. We trained 235 professionals to use this in 45 events. So we toured quite a lot in the area, and there are the municipalities where we were named. Kuopio is the biggest city at that area, so it has also the most of persons. But interestingly, there are very small places like Tuusniemi that reach in the same amount of trained people. For example, like Varkaus, which is kind of 6 times bigger than Tuusniemi. But okay, it just says that it's a little bit random how we got the message through. And where are we now? Oh, I can see it there too. Okay, this is the things that we shared with them in the trainings. So we tried to make it very simple, tried to make it as accessible as possible, so that there would be no threshold to try the first time this consultation. Okay. After these years, we are here now. We actually got this going in the beginning of 2017, and during this year and a half, we have learned that we have to change the booking system a little bit. It was too difficult to use these 3 email boxes with those pre-mentioned roles. We had to go to this, that we have 4 real persons that have their email boxes with their own names, so that things don't go, that we can manage to use them properly, yes. We had this dream that all 50 professionals that we had in the Kuopio University Hospital's Child Psychiatry department could be in the system, but it was much too difficult to do with this kind of booking system that we had. So actually, we learned last summer that we had also this kind of half a year that we did not have anything going. Even the online system was also already good and going. We have in the June 2017 the first video consultation. It took 6 months to get the first one. After it, we decided to change these online booking systems a little bit and go and shout more about us. Tell once again, repeat. We are here. Why don't you want to use us? We are cheap. We are free. And finally, we got something. And in that process, we learned also that when we were telling our story once again, we tried to learn why they are not wanting to use us, and from that feedback we tried to change the things that we are offering also. We decided to start these tutored peer groups, so that at the same time there were, for example, 5 different school nurses and school child psychologists that were online with me, and they were having some team on what to discuss. They were having their own patient stories, and we were discussing about that as a little bit more abstract way. And it kind of, yes, it was training, it was learning to both sides. Okay, then more. Next. Okay, we can just get it going. It's the first reality version of what we are doing now. These SDQs have been kind of grayed out. They are nobody seems to be using them. It was a little bit clumsy that we could get from our internet provider, so probably it has something to do with that. But anyways, there is also this kind of a similar feeling that you, Lucy, were saying about that those persons who have kind of done it over 2 times or 3 times, they will stay. They will use it more. But there has to be kind of this kind of kickstart that you get to know this system, and so that you can more easily think that you are able and allowed and to use it, and it will be useful. So it will depend on persons, and something very random who will use it. But what we have done seem to be working quite well, as you will hear later on. Otherwise, this big picture is quite similar than the old one. Both sides, primary healthcare and specialist healthcare, will do their own patient recordings, and in the middle there is this green box that says that something is then decided to do. Okay, next one. Reality 2 refers to this tutor peer groups, which have been quite successful and well-liked way to enhance the possibilities of the primary care workers. This may be even the best part of the whole project, though we did not see it coming in the beginning. Okay. All right. Then let's change.
Okay, hello. My name is Minna Pölkki, and I'm a psychologist and psychotherapist working with pregnant families and children under 4 in our clinic, infant psychiatric team in Kuopio University Hospital. So, after every VC session we sent feedback. We asked feedback right after that, and this data we are talking now, at this moment, this data we collected in January to June 2018, and we asked feedback from ourselves, our feelings, our problems or something like that right after this session, and also feedback from professionals in primary health care. So it works both ways. And it seems that most of these VC sessions have been between primary and specialist health care. I remember one occasion when it was daycare and me on other side. So some sessions were multi-professional, so there was social care or daycare school present, and workers from family counseling clinic. And in some cases, also the family and or child was present. Children under 5-year-old, which is my area in these consultations, it has been a growing tendency that parents are there with public health nurse asking advice, and I think it's clinically very effective and meaningful like that. But distances, it varies from 1 kilometer to 168 kilometers, and mean is 54 kilometers. So some car travel has been avoided, but other benefits are more important. For example, encouraging families to take part and come to see a specialist or child psychiatric professional via this VC. So maybe there are more psychological values than car traveling avoided, I think, in this our project. So, about purpose of the VC, it seems that consultation is most common, but also clinical supervision, joint patient meetings, and I don't know, but there's something else. Yes, it's tutored peer groups, Jussi mentioned already. So these two below can be put together, because even three, yes, training can be. So these tutored peer group meetings have been very popular, if I can say, in small range. Yeah. So topics covered in the VCs vary. Age of children in question are from 1 year old to 13, and in some cases this has been, like I mentioned, also support for parents, and worked as intervention as itself. There has been externalizing symptoms of child, like aggressive behavior, internalizing symptoms like anxiety, problems of withdrawal, school refusal, and panic disorder, for example. And when it comes to small children, but of course also school-aged children, regulation disorders are very often discussed, like problems in emotional regulation, like severe temper tantrums in toddlers, sensory regulation and behavior regulation, and often parents are quite overwhelmed with these problems at home, as one can imagine. And often we have discussed difficulties in parent-child interaction, but it hasn't been a theme or a topic for reservation itself, but as linked to other topics, but it has been there. Developmental language problems of small child and simultaneous worry on parent-child relationship and difficult family situation as a whole has been a topic as well. Tourette syndrome, when there was question of needing for physiotherapy. You see, you know this case better, I think, yeah. And multi-symptomology, the need for consultative assessment, advice whether or not to make referral to specialized care to us or somewhere else. And also this, we love these tutored peer group meetings. It's here again. It has been an important topic for VCs. When asked what would have been alternative to BC, they think that maybe following the situation in primary health care or something else. I think something else is, for example, sending family to family counseling clinic, for example, and maybe making a straight referral to child psychiatric care. And telephone contact, maybe it's not so horrifying than making VC for some people at the field. And also joint meeting between professionals in non-specialist services in primary health care. Our video connection very often functioned well, not always as we know, but mostly. And most often it was found comfortable to talk in the VC. And it seems that our team is a bit more optimistic than teams in primary health care, but it's positive atmosphere here anyway. And opinions in both sides were mostly appreciated in the VC. That's important, to be heard and to be understood. And the goal of the VC was reached well. There is 1 hour time for negotiating and making mutual understanding, so I think this is very good result here. And opinions of the VC in general are positive. And we think, our team thinks, and it seems that our partners in primary health care think that we can do the VC again and make it stronger and bigger and more often used, because it has plenty of clinical importance, I think, as a clinical psychologist. So.
I'm so happy to have the pockets. Okay, so one more piece of information before we go to the plans for the future. My name is Kirsi Bykachev and I worked as a project manager of this eCAP project in Finland in Pohjois-Savo region. And now I'm briefly going to show you the results of the final survey we made, administered to the target groups of our intervention. And we got the results just yesterday, so we are pretty happy that we got these kind of things to show. So during the project we have collected data for evaluating the services in different ways. First of all, after we had finished the so-called training events in the municipalities, we collected feedback on the provided training and materials. And based on that data, we have written one published article, so I will put around the handout about that. First row, first served. And then in 2017, 2018, when we realized that the service is not used as frequently, not that much as we would like it to have been used, we started to make telephone interviews with the people who had received the webcam and or loudspeakers from the project, but still hadn't used the service. So we made telephone interviews with them and asked what's the problem, why you are not using that. And based on that, we presented a poster in Inverness. So here you have also a few hands out about that in case you are interested. And the third data set is the feedback form or log sheet, which was sent to the primary healthcare workers and the Kuopio University Hospital specialists straight after each VC, which Minna just told you about. So what I'm going to present you now are the results of the end surveys, and the interest in filling in different questionnaires seems to be quite low at the moment, so we only got 35 responses when actually the target group was over 2,030 people. But some of them responded to me personally by email saying that they are not working with those things anymore. They haven't been involved in the project at all after the training session, so actually the target group is slightly smaller. But anyway, I think that we can talk about something like 18 to 20% response rates to this final survey. And as we can see here about the respondents, 36% of them were working for the Well Child clinics and therefore mainly customers of Minna. But also other sectors, other organizations were quite well presented, especially healthcare center and family counseling clinics. And also the role of school healthcare was quite okay. And talking about the professions of the respondents, the majority were public health nurses, again working in Well Child clinics or for school healthcare maybe. And we also asked their work experience in primary healthcare, and quite surprisingly it was 18 years old with the fluctuation from 2 to 36 years, and they were not only extremely young and unexperienced healthcare professionals needing specialist advice, but actually it was middle-aged people with fluctuation of age from 26 to 60 years, so it was quite different people who had used the services or at least agreed to respond to this final survey. In the beginning we asked how many times have you used a video conference, and as I said, we got these results just yesterday. We didn't have the time to translate everything into English, I'm sorry for that. But 20% responded they hadn't used it at all, but they still responded to the survey. And 20% said that they had only used it once in the training event. And 23% said that they had used the video conferencing system once in addition to the training event. And 23% answered 2 to 3 times, and we had even people who had used 4 to 5 times. So I think those are the champions that we really need to get these good practices going further. The respondents considered the child psychiatric e-health services, referring to this our booking system and the video consultation system we have been just talking about here. They are easy to use. 23% said that they totally agree, and 48% somewhat agree. And only 6% was somewhat disagreed somewhat, and 6% couldn't say. So there was nobody totally disagreeing with this statement. Next item, it has been easy to embed the use of child psychiatric e-health services as a part of my job. Still quite positive, but quite big proportion didn't say their opinion, can't disagree or agree, 22%, and 16% couldn't say, and 22% disagreed totally or somewhat, but still 9% was agreed totally, and 31% agreed somewhat. But this is something very encouraging, I think. The question or the item was called Child Psychiatric e-health services are needed, and 69% of the respondents totally agreed, and 28% somewhat agreed, and 3% couldn't say yes or no, some disagree or agree. So basically we have been doing the right things. These kind of services are needed. In addition to just asking feedback from the already introduced services, we asked the respondents' opinions for the future. How should the support from the Department of Child Psychiatry to primary healthcare organized when you think about your own working organization? So we wanted to know whether they prefer telephone consultations to video consultations, or whether they want to have regular meetings weekly or twice a month or something like that. And in this question, each respondent could pick two most suitable options, and the alternative case by case when necessary with 6 weeks waiting time was the most popular answer. So basically they are ready to wait if they get good service when they need it. But also 1.5 hour video meetings once a month were the second popular, the orange bar there. And the other options were the light blue one, short 15-minute telephone conversations weekly, or the orange one, consultation days, face-to-face, once in 6 months. And the grey bar was half a day video meetings every second month, so that wasn't very popular. And the green bar means something else, and unfortunately we didn't have time to analyze what were the other requests. And what do they consider important in child psychiatric consultation service? Getting the consultations when necessary with reasonable waiting time. But they would also like to have specialists, very deep specialists there, or somebody with wide knowledge on child psychiatric topics. So they want to have everything. And again, how should we support the primary health care? When we ask about their own perceptions about their knowledge about mental health and mental health problems of children, and totally disagreed 3% and 25% somewhat disagreed that they have the sufficient knowledge. So clearly there is room for education or need for education. But on the other hand, they don't have enough of knowledge, but still they more or less know how to act. So 6% totally agrees, 56% somewhat agrees. So we were talking yesterday with Minna that maybe this is something that if they recognize the need when to react, they know how to do, but maybe the problem is that they don't always know when is the time, what is the situation when they have to do something. And actually we thought that Jussi would be talking about the sustainability of the services, but as we are running out of time, I think I will do this. So after the eCAP project, the plan is that the Kuopio University Hospital, the Department of Child Psychiatry, will continue these services under the brand ELPSY, which comes from the eChild Psychiatry, lastenpsykiatria ELPSY. So we have different kind of services, video consultation with identified patient, which will go on as normal consultations, and they will be invoiced as normal meetings. And at the moment we are negotiating with municipalities about the two other things. What kind of agreed price shall we put on the anonymous consultations or clinical supervision? And the tutor peer groups shall also continue in the future. We hope that it can be free of charge as the education provided by the university hospital. I hope we were in time. Thank you.
Okay, thank you. We have time for a short question or comment. I'll let you have the mic.
Well,
the web service you were using for setting up the conference and the meeting, is that a commercial product or did you develop it your own? Or?
So the video conferencing tool that we were using, that's called Video Visit, and that had been used in the Kuopio University Hospital already before. And actually, during this project, we found out that this service package was not ideal for our purposes. So we are hoping that maybe in the future there will be some other products available also for our region. And also one thing that we found out during this project, that in this kind of service, actually the booking system or the appointment system is more crucial, because the linking into the video consultations has been done through the email invitation. So actually it doesn't matter which video conferencing system you are using or with video conferencing software you are using, if you can get into the meeting just by clicking the message you got to your email, but it's more crucial to make the scheduling work. Did I answer your question? And yeah, it was we didn't build it ourselves. We had the Kuopio University Hospital in-house IT service provider Istekki working with us, but it was just a purchased ready-made product, so we couldn't tailor it, unfortunately.
Okay, thank you. I think maybe we should do the discussion in lunchtime, because now we have a short break. Let's meet again in 10 minutes.